37-year-old female who had severe atopic eczema, asthma and a peanut allergy. She started the peanut allergy apparently when she was very young, and by the time she was in her teens, even just smelling peanuts caused a very severe allergic reaction. But she had no previous transfusion history, and she's been admitted to hospital for a caesarean section for hemolysis, or this is the HELP syndrome, elevated liver enzymes and a low platelet count, and a postpartum hemorrhage had occurred. So she was transfused with two units of red cells, and the second unit was started after an interval of 2 hours, and within 5 minutes of that she had difficulty breathing, she collapsed and went into cardiac arrest. Happily she was successfully resuscitated. They performed serial mast cell tryptases and found that they were raised, and this is in keeping with mast cell degranulation, of course, and the levels returned to normal 24 hours later. They performed tests for IgA levels, which was normal, a total serum IgE level greater than 5,000, normal range 5 to 120, and strongly positive IgE radio alloabsorbent test, the RAST test, to nuts, eggs and wheat. So they could only think, well, maybe one of the, or that protein. And then they questioned whether the patient herself had inadvertently ingested a known allergen. But this was quite unlikely because obviously this was post-operative. And so they actually never found out the cause of this severe reaction. Trialing is often in the news these days, and again we've looked at the signs and symptoms, acute dyspnea and hypoxia and so on. The way we would investigate it in the laboratory, we would investigate the donor HLA and HNA antibody status, and then check to see if the appropriate antigens are found in the patient. If possible, we could perform a leukocytotoxic cross-match and granulocyte cross-match if patient samples were available. Certainly, in terms of trialing, it was the third leading cause of transfusion-related death, mainly due to FFP administration. The actual instance, I think, is about 1 in 1,000 or 1 in 1,100 transfusions. And they found that it was mainly due to plasma that was being used from multiparous females who had HLA antibodies. And so it became the new policy and the new transfusion associated with graft versus host. It's a very rare complication occurring between 4 and 30 days after transfusion. And it generally occurs in immunocompromised patients or directed donations from relatives. And this is because donor T lymphocytes will mount an immune response against the recipient's lymphoid tissue. Normally they would be recognized and destroyed, but obviously in an immunocompromised patient that can't happen. Symptoms are fever, rash, liver problems, diarrhea, pancytopenia and bone marrow hyperplasia. It's almost always fatal. And as I mentioned right at the beginning, irradiated blood is used and leukodepletion, which can avoid this adverse event. And certainly there have been no cases in the UK since 2001. That's just a graph to show you the decrease to naught. Briefly, transfusion-transmitted infections. The World Health Organization said that all blood should be tested for HIV, Hep B and C, syphilis and others were appropriate depending on the region in the world. But there are all of these other considerations, again depending on whereabouts in the world you live. And there are always new and emerging pathogens. And I mentioned bacterial contamination. And possibly platelets are more at risk because they're kept at room temperature. but this has been resolved more or less because of discarding the first few mLs of any donated blood. And we have to remember that it's not just where you live in the world, but bugs like to go on holiday as well. So we have holiday-associated transmitted infections too. And this is a case from the 2007 report. There were 3 reports of bacteria determined to be actual TTIs, but the source of the contamination was never identified in any of them. There were 21 reports, but they were concluded as not being transmission-transmitted infections. In other words, the infection wasn't associated with that particular.
It's sometimes easier to say it. Here's an example. Big K is the original Hell antigen. Little k is its antithetical antigen. That's the names they were given when they were discovered. But later on, using uppercase and lowercase letters to describe antigens became unfashionable, and people used a symbol, such as KP, followed by a superscript to represent the allele. The committee is now going to go back to being a working party, but don't worry about that, to try and sort out this terminology. And the purpose of the committee was to establish a numerical terminology for blood group antigens. But as well as just being a series of numbers, it was going to have a genetical basis. So it wasn't just a list of numbers. It was going to be based around the blood group systems. So, as well as being a terminology for blood group antigens, it also became a genetical classification of blood groups. Now, this is how the terminology works.
It's likely to be more hemolysis. Distribution of the antigen on the membrane may affect the degree of complement activation. And then, if the antigen is present on other tissues, possibly as a soluble form in body fluids as well as on the red cells, this will tend to dilute out the effect of the antibody in the hemolytic potential of the antibody, so there'll be less hemolysis. If the antibody is left, the type of complements present on the circulating red cells is important. If there's C3b on the red cells, then this can cause both intravascular and extravascular destruction of the red cells through the C3b receptors on macrophages. If the C3b coated red cells escape destruction by the macrophage, the reticular endothelial system will have a higher level of hemolysis, faster hemolysis. There are 2 basic types of hemolytic transfusion reactions: immediate, otherwise known as acute reactions, and delayed reactions. And then the immediate reactions can be intravascular, with the hemolysis occurring within the circulation, or extravascular, with the hemolysis occurring. Information that we knew from the past on the clinical significance of antibodies based on their specificity. The first category are those antibodies that we know are likely to be clinically significant. So these are the antibodies where antigen-negative red cells must be selected. And of course, this includes ABO, RH antibodies, KEL antibodies, Duffy, KID, Diego antibodies, some antibodies of the M&S system, anti-Bell. And included in here, of course, is these antibodies that are loosely called anti-MIA, antibodies that we're not particularly concerned about in the UK, clearly are a problem in this part of the world. Then there's antibodies that are usually not significant, but could be if they were active at 37 degrees. So you don't have to select antigen-negative red cells. You don't have to find antigen-negative red cells for these. Any red cells will be suitable as long as they're compatible by an antiglobulin test at 37 degrees. This category also includes some antibodies that we know are likely to be clinically significant, but it's not possible to obtain antigen-negative red cells. So once again, you would select red cells that are compatible by an antiglobulin test at 37 degrees. The third category contains, again, antibodies that are considered not to be clinically significant. And these are antibodies to high-frequency antigens. So for these sort of antibodies, it's recommended that least incompatible red cells are chosen. So for most examples of the antibody, using compatible red cells, but it's a good idea to look for red cells that have
Mấy hình
low
của mình
levels
coi
of
lại mấy
expression.
hình trước chụp nó được không? Phải
But
biết
when
coi.
there are strong examples of the antibody, then it's a good idea to use
Nó được coi được
compatible
một
red
tấm
cells
rồi
if
thì
possible antigen-negative red cells.
hả?
Again, these are antibodies that really are considered not to be clinically significant, and there is no need at all to look for compatible cells. So any red cells can be used for these sort of antibodies. But again, it's prudent if the antigen is an antigen that varies in strength from individual to individual, use red cells that have a low level of expression. The fifth category is a difficult category. It's a category of antibodies that we suspect can cause transfusion reactions, are clinically significant, but it's unlikely that you're going to be able to find compatible blood. In other words, the antigen-negative phenotypes are so rare they're not available. So in this case, you would have to transfuse incompatible red cells, even though you know there's a danger of a transfusion reaction. And of course, this has to be done with extreme caution. To move on to
Hemolytic transfusion reaction. In mixtures of antibodies, we obviously need to check the suspected antibody specificity against the positive reactions obtained, evaluate the strength of different